Bismillahirrahmanirrahim. So this is the coagulation cascade that we are going to start it now. Coagulation cascade pathway. The pathway is not itself very important, but let's see it. Whenever there is a damaged surface, the damaged surface is a stimulus for the binding of kininogen and kallikrein, which convert the factor 12 to 12A. It will convert 11 to 11A, then 9 to 9A. That will convert 10 to 10A under the catalytic effect of factor 8A. Okay, so this 10A is a common pathway of intrinsic and extrinsic pathway. So intrinsic pathway contains 12, 11, then 9 and 10. 12, 11, 9 and okay, so 12, 11, 8 and 9 and 10. Okay, so 10, basically 10 is not a part of any neither intrinsic nor extrinsic pathway, so exclude 10. Other than that, 12, 11, 9 and 8 are component of intrinsic, while the factor 7 is component of extrinsic pathway. In response to trauma, the 7 is converted spontaneously into 7A, or then the tissue factors in response to trauma will cause the catalytic effect of 7A for the conversion of 10 to 10A. Then factor 5A will convert the prothrombin, which is factor 2, into thrombin, that is 2A. The 2A will convert fibrinogen factor 1 into fibrin, that is 1A. And then comes the 13A, which causes the cross-linking. This is the final common pathway. So prothrombin is 2, fibrinogen is 1. Got it. Placenta previa, posterior lying placenta, anterior lying placenta is fine. Okay. Usually diagnosed routinely at 18 to 20 weeks. It can present with severe painless hemorrhage through vagina and non-painful contractions. Irregular contractions are seen on tocodynamometry. Risk factors include prior C-section, prior placenta previa, multiple gestations due to increased placental surface area, advanced maternal age like more than 35 years, multiparity, smoking. Majority cases resolve spontaneously by third trimester due to lower segment lengthening and placental growth towards the fundus. Management. Initial management is routine obstetric care as it resolves spontaneously mostly. Pelvic rest is advised. Repeat ultrasound is performed at third trimester, that is more than 28 weeks of gestation. Asymptomatic patients undergo scheduled cesarean at 36 to 37 weeks of gestation. Many patients have reassuring prenatal monitoring initially, for example, acceleration and no deceleration, as the bleeding is primarily maternal. So placenta previa, risk factors are prior placenta previa, prior cesarean delivery, and multiple gestations. The clinical features are painless vaginal bleeding more than 20 weeks of gestation. Diagnosis is transabdominal followed by transvaginal sonogram. Management, no intercourse, no digital cervical examination, and inpatient admission for bleeding episodes. Then cervical insufficiency, it is basically when the cervix is not patent enough to hold the fetus, like it is lax or loose. It can be due to following reasons: intrinsic cervical instability, reduced cervical length, prior cervical colonization, congenital abnormalities in utero, diethylstilbestolic exposure, clear cell adenocarcinoma, vagina. In the second trimester pregnancy loss, it causes second trimester pregnancy loss. It is diagnosed by any one of the following criteria: painless cervical dilation in current pregnancy, that is examination based; a second trimester cervical length of less than 2.5 centimeter plus a prior preterm delivery, that is ultrasound based; and more than 2 prior consecutive painless second trimester losses, that is history based. So 2 prior consecutive painless second trimester losses, this is based on history. On ultrasound, if the cervical length is less than 2.5 centimeter plus a prior preterm delivery and painless cervical dilation in current pregnancy, that is examination based. So there are 3 diagnostic criteria, and any one of them should be met to make the diagnosis of cervical insufficiency. On ultrasound, there will be shortened cervix, like less than 2.5 centimeter, and a dilated cervix too, and non-vaginal bleeding is present. Symptoms are pelvic pressure and painless cervical dilation. Differentials include abortion, but in abortion there will be pain and bleeding is present. This is not seen in the cervical insufficiency. Abruption presente, there will be decelerations present and pain present. Hydatidiform mole, absent fetus on ultrasound and first trimester bleeding. Placenta previa, bleeding is present and cervix is closed. Cervical insufficiency with respect to the collagen defects, uterine abnormalities, cervical colonization, and obstetric injury. The clinical features are more than 2 prior painless second trimester losses and painless cervical dilation. Management is circlage placement. So, cervical weakness treatment, if I could zoom this picture, now you can see here that I think, yeah. So, this is cervical circlage which is placed here, and this is cervical pessary. Okay, I have to go much further. Yeah, so if you can see here, so this very thing is cervical circlage and this is cervical pessary. Moving forward, the next topic is cervical conization. So cervical conization in patients, so this is cervical cone biopsy, and this is the piece of cervix like in a form of a cone, like from here, that we take for the biopsy. So if the patient has cervical intraepithelial neoplasia 3, conization is diagnostic and therapeutic, so go with conization. Okay, so this is the normal tissue and there is a lesion in the transformation zone, so we do the cone biopsy for that. It is indicated in CIN grade 2 and 3. Colposcopy is the gold standard method for diagnosing CIN. Methods: cold knife conization via scalpel and loop electrosurgical excision procedure, that is LEEP, loop electrosurgical excision procedure, LEEP, via electrocautery. Cervical conization indications are cervical intraepithelial neoplasia grade 2 and 3. Complications include cervical stenosis, preterm birth, preterm premature rupture of membranes, and second trimester pregnancy loss. Management after conization depends on pathology results. If there is no evidence of invasive cancer and specimen margins are free of disease, that is all CIN removed, management is with PABS testing and human papilloma virus co-testing and 1 and 2 years. In contrast, patients with invasive cancers or margins with residual CIN require additional treatment. Circlage placement. It treats cervical insufficiency by reinforcing the cervix with a suture or synthetic tape. Candidates include patients with a history of second trimester deliveries, patients with short cervix less than 2.5 cm or less than 2 cm. Short cervix can also be treated with a vaginal progesterone. So this one is normal cervix, and like closed cervix looks like that. Incompetent cervix is open, like short dilated cervix and amniotic sac bulging at the os. Then we have circlage, as you can see here. So we apply the sutures to close the open or incompetent cervix. What is colposcopy? Colposcopy evaluates the cervix and vagina under the magnification after application of acetic acid to contrast and identify abnormal, for example, acido-white changes from the normal. So, like when we give the acetic acid, the areas which become white are abnormal. Abnormal vessels, a sign of high-grade lesion, also become more visible on colposcopy. It is indicated in cases of high-grade lesion, regardless of HPV status. In case of low-grade lesion, do HPV co-testing to differentiate between atypical squamous cell of undetermined significance (ASCUS), atypical squamous cells of undetermined significance, that is ASCUS, and low-grade intraepithelial lesion. Cervical intraepithelial neoplasia during pregnancy. Colposcopy can be performed during pregnancy, which is gold standard. In case of inadequate colposcopy, we normally do endocervical curettage, but it is deferred during pregnancy due to the risk of miscarriage and preterm delivery. Then cervical biopsy is performed in pregnancy if a lesion has high-grade feature, for example, abnormal vessels. So this is normal cervix as seen on colposcopy, and this cervix is having acetobyte changes after applying the acetoacetic acid. Okay, and this is how we insert a colposcope after opening the cervix with vagina, and this is cervix and vagina. Okay, then there is a syndrome that is called as the HELP syndrome. Serious liver problem include centrilobular necrosis, hematoma formation, and thrombi in the post-capillary system. These processes can cause liver swelling with distension of the hepatic or the Glissen's capsule, right upper quadrant or epigastric pain. HELP syndrome, the clinical features are preeclampsia, nausea, vomiting, and right upper quadrant abdominal pain. Lab findings include microangiopathic hemolytic anemia, elevated liver enzymes, and low platelet count. Treatment is delivery, magnesium for seizure prophylaxis, antihypertensive drugs. There's a new table about HELP syndrome. The clinical findings are nausea, vomiting, right upper quadrant pain, headache, visual changes, and hypertension. Lab abnormalities are microangiopathic hemolytic anemia, elevated liver enzymes, thrombocytopenia with or without proteinuria. Treatment is delivery, magnesium sulfate for seizure prophylaxis, antihypertensive, for example, hydralazine. Complications are abruptio placenta, subcapsular liver hematoma, acute renal failure, pulmonary edema, and disseminated intravascular coagulation. HELP means hemolysis, elevated liver enzymes, and low platelet count. So this is subcapsular hematoma. As you can see in this picture, like this thing is subcapsular hematoma. Blood clotting within the hepatic Glissen's capsule. Okay, so in severe cases can progress to liver necrosis and hemorrhage, that is subcapsular hematoma. HELP syndrome in severe cases can cause subcapsular hematoma. Then we have the next thing, that is okay, magnesium sulfate toxicity. Just give me a second. So magnesium sulfate toxicity, it is the toxicity. Its toxicity can cause neuromuscular depression. Okay, so its toxicity can cause neuromuscular depression. Got it. Then characteristics include apnea, lower motor neuron kind of picture will be there. Muscle paralysis, like lower motor neuron type of muscle picture. Then somnolence, visual disturbance, decreased or absent deep tendon reflex, respiratory depression, cardiac arrest. Renal insufficiency is a common risk factor for magnesium toxicity. The range is therapeutic range 5 to 8 milligram per deciliter. Toxic concentration of more than 8 milligram per deciliter will be there, and the antidote is calcium gluconate. Hypermagnesemia, hyperkalemia, hypocalcemia, all calcium gluconate. Then magnesium toxicity, the clinical features are, if there is mild magnesium toxicity, so there will be nausea, flushing, headache, and hyporeflexia. In moderate magnesium toxicity, there will be areflexia, hypocalcemia, and somnolence. In severe cases, we will have respiratory paralysis and cardiac arrest. Treatment is stop magnesium therapy and give intravenous calcium gluconate bolus. Then ectopic pregnancy presentation, hypotension, positive beta HCG, and vaginal bleeding. Blood in the abdomen can present with following, that is acute abdomen, cervical motion, tenderness, shoulder pain, referred pain from the diaphragm, urge to defecate, that is blood in the posterior cul-de-sac. Risk factor for cornual interstitial ectopic pregnancy include uterine abnormalities, that is bicornuate heart-shaped uterus, and in vitro fertilization. So this is like, these are the places. The most common is tubal pregnancy over here. I think it happens in ampulla. Then we have this is the ovarian ectopic pregnancy, then the tubal, then the cornual, abdominal, cervical. The cervical causes an increased chance of inevitable miscarriage. I think it is inevitable miscarriage. I think so. Then we have ectopic pregnancy. The risk factor that previous ectopic pregnancy, previous pelvic or tubal surgery, then pelvic inflammatory disease. The clinical features are abdominal pain, amenorrhea, and vaginal bleeding. Hypovolemic shock in ruptured ectopic pregnancy. Cervical motion, tenderness at an axle or abdominal tenderness with or without palpable adnexal mass. Diagnosis is positive HCG, transvaginal ultrasound revealing adnexal mass and empty uterus. Management is methotrexate and unstable. Okay, so management, if the patient is stable, give methotrexate. If the patient is unstable, do the surgery. Then we have risk of obesity in the pregnancy. Risks of obesity in the pregnancy. Obesity in pregnancy is pre-pregnancy BMI of. So risk factors include obesity. Uh, the risk factor of obesity is pre-pregnancy BMI of more than 30 kg per meter square. It increases the risk of fetal demise and fetal macrosomia, that is more than 90th percentile. Operative vaginal delivery. Operative vaginal delivery means we are delivering the baby through vagina but with the help of some vacuum assisted or forceps techniques. Indications are vacuum or forceps. So indication, protracted second stage of labor, fetal heart rate abnormalities, maternal contraindications to pushing. Fetal complications include laceration, cephalohematoma, hyperbilirubin, anemia, facial nerve palsy, intracranial hemorrhage, and shoulder dystocia. Maternal complications include genitourinary tract injury, urinary retention, and hemorrhage. Other indications of operative vaginal delivery are maternal exhaustion, maternal contraindications to Valsalva maneuver like hypertrophic cardiomyopathy. Then what is uterine inversion? It is a kind of uterine prolapse. Previous inversion is the highest risk factor. If there is a picture, there's no picture, but it is basically the uterine inverts through the cervix or vagina to the outside. The risk factors include nulliparity, fetal macrosomia, rapid labor and delivery, and placenta accreta, especially when you try to deliver placenta accreta with force. Uterine inversion can result from excessive fundal pressure and traction on the umbilical cord before placental separation. Presentation is severe lower abdominal pain, hemorrhagic shock, smooth round mass protruding through the cervix or vagina. Uterine fundus is no longer palpable transabdominally. The inverted uterus should immediately be replaced. Placental removal and administration of uterotonic drugs should be initiated only after the uterus is replaced. Otherwise, there will be stenosis and you will not be able to replace the uterus. Uterine relaxants can be used to aid in uterine replacement if the initial attempt is unsuccessful. However, reduction of an inverted uterus is preferable without uterine relaxants. The pathophysiology is excessive fundal pressure and excessive umbilical cord traction. Presentation is lower abdominal pain, round mass protruding through the cervix, uterine fundus not palpable transabdominally, and hemorrhage shock. Management is aggressive fluid replacement, manual replacement of the uterus, and placental replacement of the uterotonic drugs after the uterine replacement. What is water intoxication due to oxytocin toxicity? Oxytocin works like ADH and its toxicity can lead to water retention. So oxytocin and ADH, both of them are produced from, not basically produced, but released from the posterior pituitary. So they kind of work in the same situation. So water retention leads to hyponatremia, like dilutional hyponatremia, and that will lead to tonic clonic seizures. Management, hypertonic saline, like 3% saline. Oxytocin indication, induction or augmentation of labor, prevention and management of postpartum hemorrhage. Adverse effects include hyponatremia, hypotension, and tachysystole. Oxytocin contraindications include prior classical C-section and fetal heart decelerations. Then there is next topic is late term pregnancy. Pregnancy more than 41 weeks of gestation is late term pregnancy. Post term is more than 42 weeks. So if it is more than 41 weeks, we call it late term. If it is more than 42 weeks, then it is post term. Age related changes in placenta, for example infarction and calcification, will lead to increased placental vascular resistance that will lead to uteroplacental insufficiency, chronic fetal hypoxemia, CNS depression, and demise. To prevent CNS depression, blood is distributed preferentially to brain, that is decreased blood to the kidneys, that will lead to oligohydramnios. Signs of uteroplacental insufficiency are late decelerations on non-stress testing, oligohydramnios on ultrasound. If uteroplacental insufficiency is positive, immediate delivery due to the risk of intrauterine fetal demise is necessary. Then late and post-term pregnancy definition: late term more than 41 weeks of gestation, post-term is more than 42 weeks of gestation. Risk factors: prior post-term pregnancy, nulliparity, obesity, age more than 35, and fetal abnormalities, for example anencephaly. Complications: fetal neonatal macrosomia, dysmaturity syndrome, oligohydramnios, and demise. Maternal: severe obstetric lacerations, cesarean delivery, and postpartum hemorrhage. Management is frequent fetal monitoring, for example, non-stress testing, and deliver prior to 43 weeks of gestation. Fetal dysmaturity syndrome, dysmaturity due to increased gestational period. It occurs in post-term, more than 42 weeks gestation, pregnancy due to age-related placental changes that will lead to uteroplacental insufficiency and small neonate, thin body and loose skin. Neonatal presentation is small for gestational age, thin body with loose skin, and meconium stained amniotic fluid. Okay, fetal dysmaturity syndrome. So neonatal presentation with small for gestation, thin body with loose skin and meconium stained. Okay, so this dysmaturity is because of increased gestational period. Okay, I was just trying to differentiate it from the fetal growth restriction. So that fetal growth restriction has maternal or fetal factors and some congenital problems or decreased uteroplacental blood flow. But this maturity syndrome is occurring because of increased gestational period. How do we? No, okay, now it was still here. Now the next topic is how do we do the lumbar puncture? Needle is placed between fourth and fifth lumbar vertebrae. This is ligamentum interspinous ligament, then epidural space with anesthesia, and chordae coina. Okay, so the needle for epidural is placed outside the duvit. Got it. Then we have postpartum urinary retention. Inability to void more than 6 hours after vaginal delivery or more than 6 hours after urinary catheter removal for cesarean delivery. Presentation is overflow incontinence, that is urinary dribbling, and over-distended bladder, that is lower abdominal pressure. Causes pudendal nerve injury due to perineal trauma from prolonged second stage of labor and perineal laceration. Epidural anesthesia suppresses micturition reflex and decreased detrusor tone that will lead to bladder atony. Diagnosis: post-void residual volume of more than 150 ml. Management is intermittent urethral catheterization and resolution in less than 1 week. Postpartum urinary retention. The risk factors are primiparity, regional neuraxial anesthesia, operative vaginal delivery, perineal injury, and cesarean delivery. The clinical features are small volume voids or inability to void, incomplete bladder emptying, and dribbling of urine. Management is self-limited condition and intermittent catheterization. Perineal laceration. These are first degree tear. Like the first degree tear is that the vaginal mucosa and perineal skin is involved only. In second degree tear, the vaginal mucosa and perineal skin along with muscles like bulbocavernous muscle and perineal body is involved. In third degree tear, there is involvement of external anal sphincter along with the like vaginal mucosa and skin is torn, then bulbocavernous and perineal body, then external anal sphincter is torn. And in the fourth degree, along with all of these things, the rectal mucosa is also involved. Vaginal atrophy. It can present with urinary symptoms like urethral discomfort and stress urinary incontinence, unlikely to occur immediately postpartum due to high estrogen levels during the pregnancy. Low estrogen levels can lead to vaginal atrophy, for example, old age and lactational amenorrhea. Then we have Erb Duchenne palsy. So it is like waiter stiff. So due to the shoulder dystocia, due to fetal macrosomia, birth weight more than 4.5 kg, it is like it happens due to when you use a faulty technique for the delivery, that can happen, and this is nerve damage. It involves C5 to C7. C5 nerve root supplies the deltoid and infraspinatus. The C6 nerve root supplies the biceps, and C7 nerve root is for the wrist and finger extensors. Damage to C5 to C7 leads to weighted tip posture. It is basically injury to the brachial plexus. Management is observation and physical therapy. Because the resolution occurs within 3 months, surgical intervention can be considered if there is no improvement by age 3 to 9 months. We can give nerve graft, reconstruction, and decompression. Observation only, it resolves in few months or by 3 months. So the presentation is one arm will be normal, the other arm will be upper arm is adducted and internally rotated, elbow will be extended, and forearm will be pronated, wrist and fingers will be flexed. Then we have fetal malposition. Fetal malposition The fetal position is the relationship of fetal presenting part to the maternal pelvis. Optimal position is occipito anterior OA position. Occipital transfers can cause cephalopelvic disproportion at the second stage arrest. Molding of the caput suggests cephalopelvic disproportion. Molding and caput suggest. Okay, molding is a change in fetal skull shape as the maternal pelvis, as the maternal expulsive forces efforts sculpt the fetal head into shape of the pelvis and facilitate delivery. Basically, as you know, that the sutures of the skull are not fused when the child is born. So the main purpose of them is that when the child is delivering through the lower genital tract of the mother, so these bones will overlap each other and then they will be delivered. Caput is scalp, and that happens, and the process of overlapping of these bones and sculpting into the shape of the pelvis is called as molding. Caput is scalp edema due to prolonged tissue. Caput is scalp edema due to prolonged pressure. Okay, so this is occipital and anterior position. Left occipital anterior position. Okay, this is occipital anterior position, and this is right occipital anterior position. Occipital anterior position looks something like this. This is pelvic outlet, 9.5 centimeter diameter. Okay, and if we are talking about occipital posterior position, then the total diameter becomes 11 centimeter, and that is a difficult thing to deliver. So fetal position, the form can be cephalic, which is an ideal position, then breech position, and transverse position. This is transverse lie, as you can see in this picture. Then we have appropriate weight gain in pregnancy. Average women should increase their intake by 350 to 450 kilocalories per day during second and third trimester. Weight gain in pregnancy BMI kg per meter square. If it is less than 18.5, so ideal weight gain must be to 28 to 40, that is 12.7 to 18 kg during pregnancy. If the BMI is 18.5 to 24.9, then the weight gain should be 11.4 to 15.9 kgs. If it is 25 to 9, then the weight gain should be 6.8 to 11.4, and if it is more than 30, then 5 to 9 kg is the ideal weight gain. Complications: inadequate weight gain. If like the woman is not gaining enough weight, then there will be low birth weight in preterm delivery. If there is excessive weight gain, then gestational diabetes mellitus, fetal macrosomia, and cesarean delivery will occur. Complications of inappropriate pregnancy weight gain are excessive weight gains can lead to gestational diabetes mellitus, fetal macrosomia, and cesarean delivery. Inadequate weight gain can lead to fetal growth restriction and preterm delivery. Risk factors for fetal anemia are fetal-maternal hemorrhage, maternal alloimmunization, in utero infection, for example, parvovirus. So, fetal growth restriction can lead to polycythemia. Gastroschisis risk, it is increased with first trimester NSAID use. Continuation of menses in non-lactating mother within 10 weeks of birth. Prophylactic platelet transfusion. Normal delivery, the platelet count is less than 20,000 per millimeter cube. C-section, if the platelet count is less than 40,000 per millimeter cube. Okay. Then we have beta HCG level after pregnancy. They become undetectable 2 to 4 weeks after delivery. Increased levels are concern of gestational trophoblastic disease. Routine screening and interventions during the pregnancy. All pregnant women should receive screening for HIV, hepatitis B, chlamydia, syphilis, and illicit drugs. Anti-D immunoglobulin administration at 28 to 32 weeks of gestation. First trimester administration is justified in case of uterine bleeding. More than 72 hours after delivery, RHD negative. If the child who is born is RHD positive, group B streptococcus screening at 35 to 37 weeks because the results are valid for approximately 5 weeks. HIV screening in the first prenatal visit, as early antiretroviral therapy initiation will decrease the risk of HIV transmission to the fetus. Rescreening in high risk individuals, for example, IV drug users and multiple sexual partners. Maternal serum alpha fetoprotein measured at 15 to 20 weeks of gestation, optimally at 16 to 18 weeks. If increased, follow up with ultrasound to look for fetal anatomic defects, gestational age, or multiple gestations. Benign causes of MSAFP. What is that? Benign cases of okay, multiple gestations and incorrect gestational age demonstration. Most common cause of what is MSAFP? Let me see that. So MSAFP means maternal serum alpha fetoprotein level. Okay, it was written over here, maternal serum alpha fetoprotein. So multiple gestation and incorrect gestation age dating, most common cause. Urine culture in the first trimester to rule out asymptomatic bacteriuria because it has 40% chance of progressing to pyelonephritis because smooth muscle relaxation and urethral dilation allows urine to ascend from bladder to kidneys. Rescreening a positive culture even in the first trimester or positive risk factor like urinary tract abnormalities and sickle cell disease. Okay, so this is again like the same thing. Okay. Routine prenatal laboratory tests are as follows. Initial prenatal visit, we should do the Rh-D type antibody screen, hemoglobin, hematocrit or mean corpuscular volume, HIV, VDRL, RPR, syphilis part of routine, hepatitis B surface antigen. So these tests are for HIV, hepatitis B and syphilis, rubella and varicella immunity. Pap test if screening is indicated, chlamydia PCR if less than 25 or prior STI, urine culture and urine protein. 24 to 28 weeks, hemoglobin, hematocrit, antibody serum if Rhd negative, if the mother is suppose she has a negative blood group, and 50 gram 1 hour glucose challenge test. 35 to 37 weeks group B streptococcus culture. Okay, so if syphilis is positive and penicillin allergy is sensitive, desensitize and then give penicillin. Neural tube defect. The neural tube defect types are anencephaly, encephalocele, and spina bifida, myelomeningocele. Risk factors are low folic acid intake, methotrexate, anti-epileptics, diabetes mellitus, prior pregnancy with a neural tube defect. Prenatal screening. Second trimester ultrasound, maternal serum alpha fetoprotein. How do we prevent this? Average risk is 0.4 milligram folic acid daily and high risk 4 milligram folic acid daily. Folate supplementation. Women should take folate supplement 1 month prior to conception. Dosage in average risk patient it must be 4.4 milligram daily and in high risk patient it must be 4 milligram daily. How do we do the STI screening? So for STI screening, all the patients undergo HIV, HBV and syphilis screening at initial prenatal visit because these STIs can cause congenital infections. High-risk patients also require gonorrhea and chlamydia screening because these infections can cause preterm pre-labor rupture of membranes and neonatal infection, for example, conjunctivitis. The high-risk patients also require repeat screening for all the STIs in third trimester. High-risk STI screening in pregnancy. So high-risk patients are age less than 25 with prior history of sexually transmitted infection, high-risk sexual activity like multiple partners and commercial sex work. Required screening is performed at initial prenatal visit in third trimester. HIV, syphilis, hepatitis B virus, gonorrhea and chlamydia. Syphilis manifestations, primary syphilis, painless genital ulcer or chancre, secondary diffuse rash, palms and soles, lymphadenopathy, epitrochlear, condyloma latum, oral lesions and hepatitis. The latent syphilis is asymptomatic and tertiary syphilis is CNS, causes Davis dorsalis and dementia. In cardiovascular system causes aortic aneurysm and insufficiency, and cutaneous lesions like gomas can also be present. HIV management during pregnancy. So antepartum HIV RNA viral load at initial visit every 2 to 4 weeks after initiation or change of therapy, monthly until undetectable, then every 3 months. CD4 cell count every 3 to 6 months. Resistant testing if not previously performed. Antiretroviral therapy initiation as early as possible. Avoid amniocentesis unless viral load is less than 1000 copies per ml. Intrapartum, avoid artificial rupture of membrane, fetal scalp electrode, and operative vaginal delivery. Viral load must be less than 1000 copies per ml. Antiretroviral therapy with vaginal delivery. Viral load of more than 1000 copies per ml. Antiretroviral therapy plus zadovudine with cesarean delivery. Postpartum, for the mother, continue the antiretroviral therapy. Infant, maternal viral load less than 1000 copies per ml, give zadovudine. And for the infant, maternal viral load of more than 1000 copies per ml, multi-drug antiretroviral therapy. Syphilis in pregnancy. Screening, universal at first prenatal visit and third trimester and delivery if high risk. Serologic test, non-treponemal RPR and VDRL, treponemal FTA and ABS. Treatment is with intramuscular penicillin G, benzathine. Pregnancy effects include intrauterine fetal demise and preterm labor. Fetal effects are hepatic, hepatomegaly and jaundice, hematologic hemolytic anemia, decreased platelets, musculoskeletal long bone abnormalities, and failure to thrive. The FTABS means fluorescent triple antibody absorption. RPR is rapid plasma region, and VDL is venereal disease research laboratory test. Hepatitis C in pregnancy. The potential complications of hepatitis C can be gestational diabetes, cholestasis of pregnancy and preterm delivery, maternal management. Ribavirin is teratogenic and should be avoided. No indication for barrier protection in serodiscordant monogamous couples and hepatitis A and B vaccination. Prevention of vertical transmission. Vertical transmission is strongly associated with maternal viral load. Cesarean delivery will not. Cesarean delivery is not protective. Scalp electrodes should be avoided. Breastfeeding should be encouraged unless maternal blood present. Like if there is nipple injury, then we avoid it because it can transmit from the blood. Fetal fibronectin. Fibronectin is a glycoprotein found in the decidual chorionic interface. Normal levels high until 22 weeks of gestation, low during mid, second, and third trimesters, and again high in the third trimester. Because of decidual chorionic interface disruption due to contractions. So that is why in the third trimester they become high again. Measurements. In patients with preterm contractions between 22nd and 35th week gestation, fetal fibronectin can help distinguish between the preterm and false labor. Okay, because normally it must be low in this time frame between 22 and 35 weeks. If it is high in that period, then it is preterm labor, otherwise it is false labor. Fetal fibronectin is not tested before 22 weeks because of high rate of false positive results. Short cervix. Okay, I think it is something similar to cervical incapacity, something. I don't know. We just read a topic about cervix. Short cervix is defined as less than 2 centimeter without history of preterm labor or less than 2.5 centimeter with history of preterm labor. Prevention of preterm labor. If there is a history of preterm labor, then we give IM progesterone starting at second trimester and serial transvaginal ultrasound for cervical length measurement. If transvaginal ultrasound shows short cervix, then do circlage. No history of preterm birth with short cervix, we can give vaginal progesterone. Preterm birth prevention. If there is a history of preterm labor, if yes, give progesterone injections and transvaginal ultrasonographic CL is circlage for cervical length. I'm sorry, transvaginal ultrasound for cervical length. If it is a normal cervix, serial transvaginal ultrasound for cervical length until 24 weeks. If we have a short cervix, so circlage, serial transvaginal ultrasound for cervical length until 24 weeks. Then, if there is no history of preterm labor, again do transvaginal ultrasound of cervical length. If it is normal cervix, then give the routine prenatal care. And if it is short cervix, give vaginal progesterone. For routine prenatal care, consider serial cervical length for history of cervical surgery or other risk factors. And in vaginal progesterone, consider serial cervical length until 24 weeks. So, prenatal screening algorithm for autosomal recessive disease. Screening for autosomal recessive diseases. Okay, so maternal genetic screening. If that comes out to be negative, so no additional testing. Mother is not a carrier. Low risk for disease in child. If maternal genetic screening comes out positive for autosomal recessive diseases, then paternal genetic testing should be done. If that is negative, since it is a recessive disorder, then no additional testing is required. Father is not a carrier, low risk of disease in child. If paternal testing also comes out to be positive, definitive fetal testing like chorionic villus sampling and amniocentesis should be done. Group B streptococcal infection. Group B streptococcal infection screening is done at 35 to 37 weeks of gestation. Intrapartum penicillin is administered to prevent early onset neonatal group B streptococcal infection. In case of low risk of anaphylaxis, use cefazolin. In case of high risk of anaphylaxis, if patient is sensitive to both clindamycin and erythromycin, use clindamycin. If patient is resistant to either clinda or erythromycin or sensitivities are not available, use vancomycin along with neonatal observation and evaluation because vanco does not reach bactericidal concentration in amniotic fluid like others. Patients who should receive group B streptococcal prophylaxis. All the patients who are group B streptococcal positive or unknown and who will deliver vaginally. All the patients less than 37 weeks who will deliver by C-section if they are group B streptococcus positive or unknown and have ruptured membranes. A few patients do not undergo group B streptococcal screening because they are considered to have persistent heavy group B streptococcus colonization. They are patients having group B streptococcus asymptomatic bacteriuria, group B streptococcus UTI, and prior delivery of an infant with early onset neonatal infection. Preventing neonatal group B streptococcal infection. Antenatal screening, rectovaginal culture at 36 to 38 weeks of gestation. Then indications of intrapartum prophylaxis. So 36 to 38 weeks of gestation. Group B streptococcus bacteriuria or group B streptococcus urinary tract infection in current pregnancy regardless of treatment. Group B streptococcus positive rectovaginal culture is in current pregnancy. Unknown group B streptococcal uh, unknown group B streptococcus status plus any of the following, that is less than 37 weeks of gestation, intrapartum fever, rupture of membrane for more than 18 hours, and prior infant with early onset neonatal group B streptococcal infection. Intrapartum prophylaxis, intravenous penicillin or ampicillin is first line. If penicillin allergy gives cefazolin. Then there are Braxton Hicks contraction. These are false labor pains. Feature are mild irregular contractions, no cervical change, reactive NST, which is non-stress testing. Discharge the patient with labor precautions. Prenatal testing. First trimester combined test. Combined test means pregnancy associated plasma protein, beta hCG, and echotranslucency. So timing is 9 to 13 weeks. Advantage is early screening and disadvantage is it is not diagnostic. Cell-free fetal DNA, CFF DNA. Timing is more than 10 weeks. High sensitivity and specificity for aneuploidy, and it is also not diagnostic. Chorionic villus sampling must never be done before 10 weeks. Average is 11. So definitive karyotypic diagnosis, it is invasive and there is a risk of spontaneous abortion, although the risk is low, but still there is risk. Second trimester quadruple screen, 15 to 22 weeks, screen for neural tube defects and aneuploidy, and it is not diagnostic. Then we can do amniocentesis. Amniocentesis, yeah, like it is 15th to 20th week, definitive karyotypic diagnosis, invasive risk of membrane rupture, fetal injury and pregnancy loss. Second trimester ultrasound, 18 to 20 weeks, measure fetal growth, evaluates fetal anatomy and confirms the placenta position, cannot identify all the abnormalities, some findings are of uncertain significance. Maternal serum alpha fetoprotein, blah 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 blah. In case of abnormal first trimester combined test, go for diagnostic test, that is chorionic villus sampling at 10 to 13 weeks, amniocentesis at 15 to 20 weeks. If the patient declines invasive testing, do the following, that is anatomy ultrasound and cell-free fetal DNA test. What is quadruple test? Quadruple screening in second trimester is done for all. It is performed in second trimester from 15 to 20 weeks. Patients with abnormal quadruple test should be offered a cell-free fetal DNA testing. Ultrasound should be performed to evaluate for fetal anomalies. Abnormal quadruple tests, cell-free fetal DNA and ultrasound should be done. Okay. Quadruple has ABE, like maternal serum alpha fetoprotein, beta hCG, and estriol. Inhibin is not a part of that. So A, B, and E, they are a part of quadruple testing. What are the fourth thing? There are four things in quadruple test. Maternal serum alpha fetoprotein, beta hCG, and estriol. There's one other thing which I don't remember right now. So, and then we have inhibin A as well. So, but that is not a part of quadruple screening. Now, in trisomy 18, which is Edwards syndrome, alpha fetoprotein will be low, beta hCG will be low, estriol will be low, inhibin A will be normal. In trisomy 21, which is Down syndrome, always remember that alpha fetoprotein level is down in Down syndrome. Beta hCG will be high, estriol will be low, and inhibin A will be high. So, the beta hCG and inhibin A are high, while alpha fetoprotein and estriol are down or low. Neural tube or abdominal wall defects, alpha fetoprotein will be high and the rest will be normal. Trisomy 21, 2B beta chain, beta hCG Okay, one I what is what do they want to say? Both increased. So beta HCG and inhibin are increased. Yes, in Down syndrome, beta HCG and inhibin are increased. Everything is down except uh, high HCG inhibin. Everything is down except HCG and inhibin. What is HI? I don't know. So I mean just trying to tell you, in Down syndrome everything is down except HCG and inhibin A. Self-repeated DNA testing. Indication is maternal age more than 35. Abnormal maternal serum screening test. Sonographic finding associated with fetal aneuploidy. Previous pregnancy with fetal aneuploidy. Parental balanced Robertsonian translocation application. Screening for trisomy 21, 18, and 13, and sex chromosome aneuploidy. Fetal sex determination. So then we have acute cervicitis. The session, okay, let's keep the session till here, and we'll start with the next session from here in the next session. Until then, Allah Hafiz, fi aman Allah, and take care.